For elderly, 4-part, 3-part fracture, my choice of treatment is always fixation first, unless it's a very clear indication for a orthoplasty. Why this debate? The physical disabilities caused by proximal humerus fractures, especially in the elderly, contribute to difficulties in their self-care and activities of daily living. Let us take this resource poor lady from a village. She comes with this fracture, 3-part, 4-part, displaced. What she is interested in is to go back to her daily routine, but she may not be able to afford the whole cost of a very costly affair of a reverse shoulder arthroplasty. So, Pratmesh, there is no dilemma in my mind. For such a resource poor situation, to me, the choice would always be a good fixation. However, if I fail in my endeavor, or if there is a poor result, you always have a chance to replace them later on. But for you, there is always a debate in your mind whether to provide a total shoulder, to provide a hemi replacement, or to go for a reverse shoulder arthroplasty. The other surgeons' experiences support the finding that the fixation technique seems to be the crucial for tuberosity union even in a hemi for displaced 3-part, 4-part. And there are fixation modalities discussed for hemi also, how to provide the union amongst the tuberosities. So friends, just extend this union process to head also, and it would unite. Once it unites, it would at least function reasonably. Despite rapid medical technology development, various challenges exist in 3 and 4-part fracture. Absolutely agreed. There are multiple problems, and with the technology development, there is an increased use of reverse shoulder arthroplasty. But this has not yet reached the masses. The choice of surgical procedure to majority of the surgeons for 3-part, 4-part displaced fracture, as also to the patients and their acceptance with the resources available and the circumstances where we live, is fixation. We need X-rays in 2 planes whenever there is a 3-part, 4-part fracture, and we during surgery also what we need is simple for fixation: X-rays and imaging in 2 plane. Most of the 3-part difficult fractures are difficult to analyze, and therefore we need to understand them under traction and to get the proper orientation with CT scan, etc., so that we can plan our fixation very effectively. There are many challenges, agreed, totally. There are a lot of failures you would be showing. I would not be showing any failure of orthoplasty. I accept it to be a very, very classical, technologically advanced procedure, but there are so many difficult problems in fixation. The proper reduction, screw purchase, etc., all this all of us know, and there would be difficulty in proper reduction as well to properly orient the radial head. Still, and there are problems in the bone morphology, poor bone content, especially in osteoporotic part where we live in India. But if we get 5 evenly distributed good fixation in a philos, or we prevent a varus collapse and we provide a bone healing potential to the original native head by preventing virus in our fixation, to providing biological fixation, or to provide a philos fixation and varus prevention. If we take care of these few steps, we'll be able to provide a reasonable shoulder function. Have a good philos plate, have a varus prevention strategy, avoid varus collapse, whatever way we can do it, proper tuberosity suture, provide graft whenever indicated, provide a medial hinge and protect it, and provide a good fixation with philos. There is a lot of emphasis on prevention of varus, and if we take care of that, provide bone substance for healing. Most of this healing goes on till end in our life. Even 90 years and 95 year intertrochanteric, we would provide fixation. So why not for humeral head? It has no weight bearing, so it would heal. Once it heals, it would provide a reasonable function. Just get the tuberosity hold, have the lifting of head. Pay attention to this slide. What goes wrong in a proximal humerus fracture is the head sinks in. The tuberosity are way apart because the head sinks in. Get the head into position, lift it up. Lift it up biologically or with plate, and it would do proper function. Put your plate correctly. Pay attention to this technique so that you have less failures. Mechanics and pearls for achieving stable reduction should be obtained. Provide a good fixation, a calca screw, varus avoided. Choose your implant appropriately. When head is like an empty shell, a biological strategy works better. So provide biology, lift up your head, get back into position, provide genial fixation, percutaneous fixation, jack up the head. So you do all these things, get a stable fixation. Look at this lady, even with a crumpled bone, absolutely nothing there. I would accept that the GT is not in proper position, but it works like a hemi at least, and the lady is quite happy from her farm. Results, majority will get functional range of motion. There are n number of complications enumerated for fixation, but if we take care of those 5 points, the result would be reasonable. However, some long-term good results points me and encourages me to get fixation for all of these fractures. All these difficult fractures are all fixable. We just have to employ it. Look at this bad fracture. Get the head in position, provide the natural construct, plan your GNL fixation or plan your philos effectively. The key is good tuberosity control, good shape, avoid varus, and then fixation technique seems to be crucial for the proper technique seems to be crucial for getting a good result. So even in all these difficult patient, I would, even with a very small head, like to provide them with a biological fixation, get the head in position. Look at the early flowing callus, even at the early age, at 6 weeks itself. Lot of good bone forms at this age also. What you need to take care of is providing the alignment, which is our main job. Get the tuberosity and head right, provide a biology, and then this biological ways would provide a good healing even in this fracture. So Pratmesh, I presume you would agree for majority fixation would be the gold standard. Thank you so much.